Hello everyone, today we will be discussing the updated guidelines on how to manage pediatric seizures in the emergency room. Make sure to like and subscribe so you can stay updated on all the lectures we will be posting. Also, if you want me to cover any topic of any of your med school subject, drop it in the comments. I will make another lecture on the detailed theory of fits in children at a later time. For now we will discuss just the emergency management. Firstly, when a child comes to the emergency room while having a seizure, like any other emergency, start the management by assessing and managing the airway, breathing, circulation and disability. While making sure that the airway is patent, the child is breathing and his oxygen saturation is stabilized, which often requires high flow oxygen. Quickly establish IV access. In case IV access cannot be established, we will discuss in a minute how to deal with that as well. Make sure to check all the vitals of the child and remember, never, ever, forget to check the blood sugar. As you can see, here we have the updated algorithm, with timestamps, for the management of pediatric seizures, in the emergency setup. Step 1, the first-line drug of choice for seizures, remain the benzodiazepines. Immediately administer IV lorazepam at the dose of 0.1 mg per kg. But remember that the maximum dose of lorazepam is only 4 mg. In case that lorazepam is not available, an alternative that is often used is IV midazolam at a stat dose of 0.2 mg per kg. However, it should be noted that lorazepam remains the more effective option. In the case that you are unable to establish IV access, however, you can either go for buccal midazolam or rectal diazepam. Doses can be seen on your screen. After that, observe for 5 minutes, but keep the second shot of benzos at the ready. Make sure that the child's airway is patent, his breathing and circulation are all stable. If the seizure doesn't stop after 5 minutes, you move to Step 2. Repeat the benzodiazepine given in Step 1. However, it is crucial to remember that you can only give a maximum of 2 doses of benzos, and this includes any pre-hospital administration, for example, by the paramedics. After this, you once again observe for 5 minutes, while getting the second line of drug ready. If the seizure still hasn't stopped after 5 minutes, then you move to Step 3. Levetiracetam, phenytoin, phosphonetoin, phenobarbital and sodium valproate are all considered to be equally effective second-line treatment for managing a convulsion that has not responded to initial benzodiazepines. Your choice of second-line drug may vary according to your location. However, according to NHS UK guidelines, the second drug of choice is recommended to be levetiracetam, 40 mg per kg, with a max dose of 3 grams. Given over 5 minutes as an infusion. After the infusion is finished, you observe for 10 more minutes. In case the fits still don't settle, then it is recommended to have the anesthetists go for rapid sequence induction with ketamine 1 to 2 mg per kg. And in the case that the team is not ready for immediate RSI, you can start either a phenytoin or a phenobarbital infusion while you wait. In case the seizure stops with just that, you can avoid going for ketamine, stabilize the patient, and then shift your focus from emergency to long-term management of the patient. That we will cover in another lecture. Thank you and hope you learned something today. I am Dr. Waqas Khan, a pediatric resident. See you later.